Thanks again to that really fabulous panel. I'd like to invite the final panel up to the table here. Melinda Abrams from the Commonwealth Fund, Bruce Chernoff from SCAN Foundation, John Goldman from the Institute for Health Care Improvement, and Susan Mendy from the Robert Wood Johnson Foundation. We have three more things before us this afternoon. One is we're going to build on this really fabulous discussion that we've heard over the last couple of hours and talk about next steps. Now, what are the priorities moving forward? How do we advance progress? Two, we're going to hear some wrap-up comments and both a summary and a charge based on what we hear in this panel from Peter and Jeff. And then we're going to have a reception. We have no formal break built in, so feel free to step out if you need to, but we will have a very nice opportunity at the end of the next hour to get together and continue the conversation. We've had some really important ideas that were identified, suggestions, if you will, for moving forward in the course of the conversation. We have some hints in your folder. You see a reference to the playbook that the multi-foundation activity has pulled together to identify some key opportunities. Peter referenced in one of his slides on opportunities moving forward. And then in the course of the last hour or so, we've also heard a number of specific possibilities pegging off, in many ways, Peter's slide on opportunities. We heard from Jamia opportunities related to co-design as well as to the needs of caregivers. We heard from Dave reference to the potential from predictive analytics, as well as the charge of engaging the invisible, if you will, for lack of a better term. We heard from Anne about the importance of consumer demand and also the importance of perhaps identifying some index questions that could help serve as a tool for the use of the taxonomy. From Jeff, we heard about the importance of, a variety of things, but clearly the issue of scaling as we move to build on what we already know and what has been underscored in the report. And learning in that respect, not only from super utilizers, but super underutilizers, and so that we're ensuring our lessons are balanced and taken from all sides. From Renew, again, among other things, she underscored the utility and the contribution of the taxonomy, but also urged that we grow the taxonomy and learn from it as we move forward. Peter started us off on that tack by indicating the humility of the planning committee as they started the process. And from Stephen, he emphasized the importance of continuing to clarify the role of functional status in the taxonomic activity, and then perhaps as a clear challenge, he asked the question of how do we go big? And that's really, in many ways, what it's about. How do we build in the interface between medical and social services into the payment models? How do we engage the relative roles and role players when we're simultaneously engaging the fundamental need for a population-wide value perspective of all taking advantage of what we've learned about our high-need population. So again, we have just a perfect panel to reflect, and each of them will take about 7 minutes for reflection on how we advance progress moving forward. and then we'll open it up for Q's and A's before we move to our wrap-up session. First, Melinda, may I turn to you? Melinda has been the point person. She's the vice president of the Commonwealth Fund, has been the point person for their many often referenced contributions during the course of the day for healthcare delivery system, and in particular the focus on high-need patients. Melinda?
Thank you very much. And I also want to just thank the Peterson Center on Healthcare. So it's not very often that I'm asked to come in when I actually haven't funded anything. So but really, Jeff and Emily really embraced me as part of their team, and I really want to thank you for that. Also want to thank Mike and the whole NAM, all the NAM staff did a really outstanding job shepherding this along, planning each workshop, and synthesizing everything was really terrific. And of course, our fearless leader, Peter Long, who called me up and said, I don't really know anything about this topic. So what, but I've downloaded all these things and I've done all this reading. And then he proceeded to talk for 40 minutes and I'm like, you've got it under control, don't worry. So really, and did a phenomenal job of again, holding us together.
Every conversation with Peter is like that.
Right. I don't know anything. Okay. So, well, that's good to know. So it's really hard to be on the last panel because everything's kind of been said. So, I'm going to try not to repeat too much, but I have to say, from my perspective, what a pleasure it is to see this work come together. This has been 2 years of this committee, but a few more than that, of just a ton of work by a lot of us and grantees and researchers across the country. And it's really, I'm really so pleased. It's a really good day. I have to say, I'm very happy today. 4 key takeaways, if nothing else, and this is where I'm going to repeat some of the prior speakers. One, and Anne's kind of said this already, the system is failing high-need patients. And part of the reason it's failing high-need patients is because their needs are not just medical, and that we are looking at them as health, we're healthcare-oriented and health providers, and really their needs are complex. It's complicated, but it's about behavioral health, social needs, and medical needs. So 1, very complex. 2, heterogeneous population. Yes, a lot of people have talked about taxonomy. I can't tell you how tickled I am to sit in a meeting where people are so excited to talk about segmentation and taxonomy. It used to be, I was like the only one on the phone, to talk about that. So I'm glad other people have gotten the bug. And so third is that while we have a long way to go and a lot to learn, there are models that give us hope, and there are some models that work. And part of the humility that you hear in Chapter 3 on the taxonomy and then on the models was Jeff Brenner in my head, not because, because I would, in particular, because we would have these very spirited conversations where I'd say, there are 22 successful models, and he'd say, there's no model. Like, he's like, we don't really know anything. We're in our infancy. And I'd be like, have to call him up, and I'd try to understand, like, well, I think that, because I'm also an optimist, and I think that it's a way to, so it just took me a while to realize that it's just that we have enough to move forward, but we still have a lot to learn. And the fourth takeaway that I think that everyone should walk away with is the important role of value-based payment. That without the value-based payment, without kind of enhanced payment, more payment, and value-based payment, we will not be able to blend and braid the healthcare services, the needs, the functional needs of high-need people, the social services, and the behavioral health needs. So those, in my view, are the 4 key takeaways. But what it means in terms of going forward is we have a ton of work to do. Steve you hit it on the head with exactly what we were trying to accomplish with the segmentation. It was, as Greg Meyer said to me, he's the chief clinical officer at Partners, he said, Melinda, the reason we need to segment is to match interventions to the people they're supposed to serve. Like, it was a very practical notion. And so when this report, at least at some level, was really, or this work was at many levels like conceptualized for the health system leadership and for the payers. And I understand that the payers and the providers will use the taxonomy differently, because I do think that there should be some risk adjustment and some enhanced payment based on the needs of the patient. But my point really is that we have, in terms of the next steps, and people have said this, is that we need to understand if it works. Like, are any ACOs doing this? I have a grant on that, and I'll tell you the story in advance, which is no. There are a lot of them are doing risk stratification. So this is with the whole thing about to stratify, to segment. I don't know if this exactly answers Rainu's question, but they're doing the high risk, rising risk, low risk. But that's actually not what we're talking about. When we're talking about segment, is like among the high risk, breaking them into subgroups so we can match them to the intervention appropriately. And we are finding like two, and they've interviewed and done an environmental scan. So I think that there's a lot of work that still needs to be done to effectively segment, although people are trying, but I think there's a lot of work there. There's also a ton of work on the taxonomy piece about figuring it out at the front lines. So when the committee that worked on this, we kept thinking about the leadership for planning purposes. And again, very anxious. I was very anxious about some of this work because I didn't want people to think like, oh, well, then I could go ahead and just use this in my practice. But like, no, that's not. This is like more, this is based on the literature, but this is based on some data analysis. This is based on some experience, but this is not necessarily meant to be applied tomorrow. And one of the things that I learned in leading that subcommittee was how much passion there is around, well, do you start with their clinical needs? Do you start with utilization? What about social service needs? Maybe we should turn the whole thing on their head and we should start with social service needs. Wait a second, but we're healthcare providers. I mean, we went back and forth, and really it looks like a very simple graphic and like, oh, of course, that's totally, but it took a long time to get to that point. And I think that I appreciate the enthusiasm and spirited and collaboration that went on, but I think we still have a lot to do on the pressure testing. So Rainu, I'm really curious to hear about what you're learning with your work. I will just say one other thing as already to kind of signal some impact. Had a lunch yesterday with, or 2 days ago, it was yesterday, with a guy from Canada who's working with the health ministry, and he's working with several provinces, but particularly with Ontario. And they're like, oh, so that, he pulled out from his briefcase PowerPoint slides from NAM workshops and said, we're going to go forward with this segmentation. And I blanched, and I was like, great. I was like, it's just a starter set. And he said, yeah, but we're going to test it, and we'll send you all the data, and we'll work as we've got also more data. So I really do think that a lot of this work is beginning to have an impact. The second big thing going forward that we need to do is better tools for implementation. A lot of people talked about this. So, we do need more of a roadmap. Thankfully, we are working with other foundations and co-funding the IHI on the playbook that will give us some, begin to, point us in this direction. But we need to create what we've heard from the field is the need not just a network to share data, as Rainu talked about, but a network of implementers, network of people where they can share their experience and share their data. The other piece that we really don't know yet, and this is another component on the spread and scale, is a better understanding of the contextual factors and the market factors and what's going on that enables something to really spread. I would also add as a third on the kind of moving forward, kind of going from what's here to where we need to go, is better understanding and improving and promoting the financial incentives. We're still at very rudimentary stages there. Finally, I would say that it is, and there have been some references to this so far this afternoon, it's timely to have this conversation, particularly amid a national debate about repeal and replace of the Affordable Care Act. because it really could dramatically affect high-need patients, and that the changes in Medicaid will affect this patient population. That we can't forget that like about half of sicker adults ages 50 to 64 are covered by Medicaid, and they have fewer resources to begin with, and that the cuts and the state decision, will disproportionately affect millions of people. So while we go forward and we think about spread and scale, we do have to also somewhat remember the national context. And the good news is that the repeal and replace proposals don't actually affect a lot of the delivery system provisions that were put in place in the Affordable Care Act. But the beneficiaries, the people, will very much be affected, and it will be another challenge that we face as we try to move forward and we try to advance care for this high-need, very high-need population. So with that, I'm going to turn it over to Mike or Bruce.
Thank you.